So this I call a perfect ROC patient. So this 63-year-old male guy presented to, by the way, OPD, he presented with an attender who was actually symptomatic for some other symptoms. And he had both leg pain. He had already visited hip surgeon, already visited knee surgeon, and then landed up with me. Occasional numbness in all four limbs. Duration was approximately 2 months. No known comorbidities. On examination, had overall higher functions normal. SLR was free since it was more of a leg pain he had. Power was 5 by 5 in both the lower limbs. The reflexes, though, were exaggerated. Bilateral Hoffmans were positive. Hyperreflexia, bilateral Babinski's tests were positive. This is the only MRI he had. He carried a bag with a screen full of screening MRI. So sorry for the image. That's the only MRI he had at the time of visit. And it shows quite a good stenosis at 5667, a subtle listhesis at 45, and more of a degenerative changes. Had neck pain on and off. So on obviously jotting down the MGOS score, it was 16, which classifies well within the mild myelopathy scenario. Here is a trick question. Like he had hardly any symptoms, more of a leg and few numbness here and there. How do you proceed? So I would like here take an opinion from the panelists. Vikas sir, would you go offer surgery? He'll be very shocked if you offer surgery because he hardly had any symptoms.
If he is asymptomatic, I will not do anything. I'll just start him on conservative treatment in the sense, ask him to do exercises and maybe supportive treatment like gabapentin or pregabalin.
Right. So Rahul sir, any?
Yeah, I think if it's not symptomatic much, we just need to counsel and we need to let him know that this is a real problem and it can worsen and he may need a surgical intervention. But I think at this stage, I think we need to keep it to the patient only. If he wants to buy the surgery, I think I'm not going to push him for the surgery. I'm still considering the conservative option.
Right. Himanshu, any other opinion? Do you in for a surgery?
No, not at all.
63-year-old.
Same opinion. He has no symptoms. He has not come to you for his primary treatment. He has come with a bystander. Yes. So there is a risk of you overselling the surgery and you being labeled as an over-aggressive surgeon also. So there is no need of surgery, right? But you have to counsel him that he may land up into trouble and close follow-up is very much necessary. So that is one counseling which is necessary.
What is this close follow-up? Like many times they ask like, when do I come? Do I really need to come, or do you explain certain red flags to them if at all you need to explain?
Yeah. Exactly. I think explanation of red flags, which are very common, which we, and I don't think there is any duration of close follow-up which is mentioned in the literature as such, that he should be coming within 6 weeks or whatever. So I think close follow-up should be 2 months, but that is very subjective. This is what I feel. Right. 2 months follow-up is fine, but you have to explain him the red flags, and if any of that appears, he has to report you as soon as possible. Right. That's the only thing that you can tell.
Yes. So, sir, any prognostication you do on such patients? Like, can we say that this is the patient who is probably going to land up in surgery sooner or later, and catch them up early and tell that yes, be aggressive and tell. So better to do the surgery because it's anyway going to progress. There is hardly any role of conservative management. Is there any role, sir?
So my threshold is very low in these kind of cases. When there is early myelopathy and we have to explain, like every rest of the panelists already explained, you need to counsel them properly. And if it worsens, the results of surgery won't be that good. So my threshold is very low. I would offer him surgery. Also can give an option of a conservative treatment, have an on-table discussion, have a lengthy discussion. Right. What are the pros and cons of conservative versus early surgery, the benefits and all, and then proceed accordingly. But I would offer him surgery at this.
Yes, sir. Faisal sir, any particular scenario where you will definitely say, ki go for conservative, that you're going to get better? If at all there is slightly worsening, you're expecting majority of the myelopathy cases in a step ladder fashion. There are any cases like where the structural or conservative trial has a bigger role compared to a surgical trial? Is there something like a soft disc, if you see in an elderly gentleman, though it is rare, but then at times we do see, most of them are traumatic disc, but then you see a soft disc, do you offer them structural conservative trial or you straight away say?
Offer them conservative.
Yes. So, any particular role of immobilization, anything you advise, or any do's and don'ts specific to the
There is
patients?
no role of immobilization in such patients.
Right,
We can offer just medicine management. We can offer them.
right. So, this was the dilemma. So, it's been already out in public that the moderate and the severe canal stenosis or severe myelopathic patients, they need to undergo surgery. So, there was this guideline paper in AO Spine, which was headed by Michael Fellings, and there was quite a very low to low evidence suggesting, and the strength of recommendation was also weak in case of mild symptom with severe canal stenosis. And there is a slightest of role in structure rehabilitation, probably for the soft disc and the dynamic compression. We discussed you follow up with radiological ways or you follow up clinical ways. So that's an interesting paper. This was in 2021 itself. That presentation of the first neurological symptoms in the degenerative cervical myelopathy. Those who present with motor deficit and gaze disturbance as the first symptom of degenerative cervical myelopathy tend to have negative predictors and probably worsen early over the time. MRI is still not clear, the T2 hypointensity versus T1 hypointensity, the magnitude of cord compression, the advancements which are available, they are more in favor of outcome based, which are going to improve, which are not going to improve. But to catch them up early and offer them surgery is quite difficult in these scenarios. There is a good paper that cerebrum changes are probably being recorded. There is seem to be a decrease in the cortical motor activity and increase in the supplementary motor activity, which has some diagnostic as well as therapeutic purpose. There is a slightest of role of dynamic MRIs. At times we don't see much compression, but a dynamic MRI will show us the dynamic compression, specifically in flexion myelopathy like Hirayama disease. Some role of the laboratory markers like serum microRNA, choline, NNA concentration ratio. But again, none of them really pick them up early and tell us that these are the cases we should offer surgery and the others, the conservative trial. Interestingly, this patient turned up to me after 7.5 months with both leg pain, again, persistent leg pain, increased numbness in all four limbs, fine motor actions severely affected. He had instability while walking. Patient who came actually walking at the first instance came on wheelchair at the second instance. Higher functions were normal, power was bilateral grip weakness, poor, other power was almost 4 to 3 by 5, and there was obvious reflexes which were exaggerated. He had a MJOA drop from 16 down to 10, with now explaining a moderate myelopathy. These were the X-ray changes he had. Obviously, I told him to get the detailed MRI at that time, but he refused that. I hardly have any cervical symptom. Why do you offer now? This time he agreed. He got the X-ray done, the MRI done. Here you can see a two-level stenosis, more specifically at 5667 with a focal kyphosis there, and a subtle instability at 4-5. These were the T1 images, and these were the axial cuts at C34, 45, 5667, majorly at 5667. And these were the dynamic X-rays which suggest there is a instability picture at 4-5 and two-level stenosis at 5-6 and 6-7, aggravated disc degeneration at this level. So any particular plan here from the faculty, again, Vikas sir, anterior versus posterior?
In this situation, I'll prefer doing anterior.
Okay. 3-level anterior or just do the 2-level
Two-level, I think
and
two-
observe the 4-5? Okay. Anyone against?
Anterior only, I think that would be preferred.
Okay.
2-level anterior only.
Okay.
Yeah, I think we are in.
So 2-level anterior, corpectomy with a cage and also deal with that C4-5 also it would be tackled in that.
Yes. Any role for Relusol? Anyone? It's a new kid on the block. Been tried, tested. Anyone for that? So anterior versus posterior is a matter of debate. I think it was well covered up in the prior lectures that when to do anterior, when to do posterior. So this patient underwent surgery, now doing fine. He improved from neuric grade 3 down to neuric grade 1 now. So he's on the road of recovery. This was only 6 months back surgery done.